Hello, everyone. Welcome to this patient-focused webinar. I'm Sam Shui from Insight Tech, and I'm pleased to be a part of today's virtual educational event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. It looks like we have a great number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Krishna and Dr. Roque from the University of North Carolina at Chapel Hill as they discuss treatment options for essential tremor, overview, diagnosis, and how to approach your doctor. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen. We will have time after the presentation to answer the questions that are asked within the chat. Let me begin by introducing you to today's presenters, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He is an early adopter of focused ultrasound technology and is considered a thought leader in the field. As a surgeon scientist, he focuses on research to optimize the focused ultrasound technique to improve patient outcomes. Dr. Roque is a board-certified neurologist and movement disorder specialist with a specific expertise diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremors through both traditional and innovative methods, seeking out quality of life initiatives for patients with movement disorders. He serves on multiple regional and national forums aimed at improving outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, and thank you for presenting this afternoon. The floor is yours.
Thank you, Sam. We are very excited to be here, and we want to thank all the participants who have found time from their daily schedule to be a part of this webinar. We are very excited to connect with you and talk to you about essential tremor and tremor in general, and how to manage that. I'd like to begin by saying Happy New Year to all the participants and the Insight Tech team. As the year starts, Dr. Roque and I thought that we would do a summary of all the webinars that we have done last year and go through some of the nuances around the diagnosis of essential tremor. As Dr. Roque likes to say, not all tremors are the same, right? And so the idea being that even though you may have tremor, the underlying diagnosis may be different. And it's important to understand what kind of tremor symptoms we are having, and so that it can be appropriately diagnosed and then managed. And then we'll go into the medical treatment of tremors, what medications are effective, and what to expect in terms of overall effectiveness, and look out for any side effects that may come with those. And then we'll do a brief summary about the surgical management when the medications are not as effective or they are causing side effects. Important thing to remember is that the details of the surgical management we'll discuss in the March webinar. So as we celebrate Essential Tremor Awareness Month in March, we would have a webinar where we would be talking about the surgical management of essential tremor. I'd like to also let you know that given the excitement that we have seen from the participants around the webinar, we continue to expand the outreach efforts. And in March, we're doing a webinar for providers, physicians, nurse practitioners, and PAs, who take care of patients with essential tremors in various clinics, family medicine, internal medicine, neurology, and movement disorder neurology, and talk about different types of tremor syndromes and their management. So without taking further time, I'd like to invite my colleague and partner from the neurology side, Dr. Danny Roque. Dr. Roque is an expert in movement disorders, and in particular, he has expertise in what we call as hyperkinetic movement disorders, so tremor and related disorders. Dr. Roque specializes in that, and together we run a tremor interdisciplinary clinic, which is a very unique clinic, probably one among the first in the country to look at patients with tremor in a holistic, multidisciplinary way. So, Dr. Roque, the floor is yours.
Thank you so much, Dr. Krishna. And let me pull up the slides here a moment, but as I'm doing that, I want to welcome everyone to the webinar. Thank you so much for coming in and participating. And hopefully this is now sharing. I will pull this up as such. So let me just pull this down. Very good. All right. So, so again, as Dr. Krishna was alluding to, our goal today is to kind of run through the gamut of possibilities instead of focusing on just one of the specific approaches that are available for folks who have essential tremor at different degrees of their condition. And hopefully through that effort, and this is my quick disclosures, I do consult with the Focus Ultrasound Foundation. But my hope here is that we can, again, as Dr. Krishna was saying, solidify the diagnosis and otherwise try to parse out where the absence of this diagnosis but presence of tremor needs to be directed toward some other methodology for treatment, but maybe even for diagnostic purposes. We could also review the conservative treatment options alongside medication options. So this is where treating more minimally would be relevant. Then talk about the minimally invasive options, surgical techniques that are available, where focused ultrasound will certainly be a topic we raise, and understanding the risks and side effects associated with those procedures. And then ultimately leave you with a couple of slides to meet our team more comprehensively here. So this first step, very crucial to movement disorder specialists, arguably to neurologists in general, but certainly on our end, we really want to get this diagnosis correct. We spent the last part of almost 3 decades trying to separate tremor syndromes from each other, and it proved very difficult. And a lot of this has to do with the understanding that these specific kinds of tremor syndromes, the uniqueness of them, respond to different treatment options, whether it's medications, conservative options, or honestly, even the available surgical options. We have to approach the treatment differently than in essential tremor. Rest tremor, as we'll learn about in a moment, certainly can be present with essential tremor, as can dystonia. But and then, of course, if a medication was the cause of tremor, but the pure cause of tremor, goal here would be to focus on eliminating that medication if at all possible. And thankfully, just over the course of the last, at this point, almost 9 years, 8 to 9 years, we're working on an improved sense of diagnosing essential tremor, something that we're still trying to get the message out to providers in the community so they understand that we need to be very thoughtful when we apply a label of essential tremor to someone who has newfound tremor, something that's very recent for you. So again, what is it, the diagnosis? The first important step to the new diagnostic criteria for essential tremor is the fact that tremor must be present in both arms with action. So it doesn't have to be present evenly or equally in both arms, just needs to be present in both arms with action. It could include tremor in other locations. Other parts of the body may have tremor, but it's not required. And the tremor in both arms should be present for at least 3 years to give time for us to be able to potentially provide a different diagnosis if in fact it starts to, whatever the underlying condition is mimicking essential tremor as opposed to truly being essential tremor. And a lot of this has to do with the unfortunate scenario that we don't yet have any available tests that diagnose essential tremor. It is a clinical diagnosis. We use your history, your examination, and any testing that we do is really to eliminate other options, other concepts, other conditions to the best degree possible. Action tremors, which qualify for essential tremor, include postural tremor and intention tremor. Postural tremor is when you're holding onto an item or just holding that posture in the arm for a fixed position for a fixed period of time, and the tremor immediately manifests itself upon holding that posture. We talk about holding a book or a cup or a plate. Perhaps just a pencil or pen. For those who like painting, it can happen upon reaching an easel. Intention tremor is more as you approach a target, specifically as you approach a target. So this is shaking that develops en route. So handwriting often gets quoted in this manner, reaching for a cupboard, threading a needle, for those who like tying a hook to a fishing line. These are scenarios with intention. You are performing an action actively instead of simply holding a posture. So either of those would qualify for action tremors that lead to the diagnosis of essential tremor. And here are just the ways that we can assess this, whether you're at home and wish to try this, or perhaps your neurologist or providers otherwise have shown you these postures and activities to try in clinic to help them sort out through the different types of tremors. With posture, we have the extension tremor. You reach out for right in front of you, and you can see that with arms, with shoulders flexed, elbows extended, perhaps wrists straight ahead. Wing beating is more of this, bring the elbows away from the core of the body. You may understand if you have essential tremor that upon doing that, you don't get to brace your elbows against your core, and so that can enhance tremor in that fashion. And then again, intention tremor, as we mentioned in the last slide, is more about reaching for a target. So this is where they may have you touch their finger, have you touch your nose or your chin, and come back and forth to assess that tremor. And then I was alluding to this earlier, rest tremor. So tremor truly present when you are completely relaxed, or as we've spoken in other forums, we've talked about re-emergent tremor, which is a tremor that is only present after holding a posture for seconds or minutes at a time, and then it develops over time and grows over seconds as well, as opposed to being a fixed tremor. So rest tremor, re-emergent tremor can occur with essential tremor, and doesn't necessarily mean, as you might be aware, that you are suffering as well from Parkinson's disease. Although the clear portion here, the asterisk and all this, is essential tremor does predispose some folks to developing Parkinson's as well. We think it's about a 1 in 20 chance, and that's a rough estimate, that if you have essential tremor at some point in your life, you may also develop Parkinson's. But having the rest tremor is not enough to qualify. And moreover, we know that up to a quarter of patients with essential tremor can have rest tremor simultaneously. And the treatment for both of those tremor types is different. We can perform something called a DAT scan, which is we're seeing an image of it on the right-hand side here, where we can look at the activity level of a specific transmitter or protein called dopamine, and how well it uptakes in these parts of the brain. If there's abnormal uptake, this could be suggestive of Parkinson's. So for someone who has a known history of essential tremor and there's any question about whether there's additional development of Parkinson's disease, this can be a useful tool for some. And I already alluded to the fact that treatment is different. So the natural evolution of tremor, and essential tremor is no stranger to this, is progression. Now, progression is quite variable even within families. So we can see that within a given family, one generation is developing tremor in their 50s with a slow progression into their 70s. The next generation picks up tremor in their teens with a rapid progression over 5 years to severe impairment. We only understand that progression is the expectation, but the speed and severity are things that we don't quite have a good handle on. We're still actively studying. And spreading of the tremor, as we alluded to with the criteria for diagnosing tremor, essential tremor, it commonly spreads. So it is not uncommon to hear folks feel that although the hand tremor may be the worst type of tremor that they're experiencing, or the most intrusive type of tremor, that they can appreciate tremor in their voice, or that family members see tremor in their head, in their trunk, maybe in their legs. So these are common features. How do we help folks who experience tremor? So there's more traditional approaches, like we think of this as symptomatic management, since we don't unfortunately have any cures for essential tremor outright. In truth, we think first about the features of tremor to help us understand the best technique for suppressing the tremor. So really categorizing that tremor. Is it postural? Is it intention tremor? Which part of the body is affected and in what format? Before we pursue an option, but the options that are available on the market, at least at present, none of those medications, none of those pills or even injections that we can chat about in a moment were ever designed for tremor suppression. So this is a key feature that we keep in mind even as we offer treatment options to patients. Then there's occupational therapy, a bit more conservative, but nonetheless getting at the heart of how do we reduce the impact of tremor on your daily activities. Um, um, there's quite a few different activities that an occupational therapist can have you try to perform in order to match with the hobbies or specific fine motor skills you're trying to tap into. So knowing again the tremor type can be helpful for the occupational therapist to identify what kind of techniques would be helpful for you to reduce the impact of tremor, whether they recommend using an adaptive device or they recommend doing something more specific to your limb to reduce the impact of tremor therein. This is where some of the weight-based therapies comes in. This is a bit more useful for postural tremor than intention tremor. Involuntary tremors just can't, so truly involuntary tremors that you cannot control just can't achieve the same amplitude, the same size when weight is applied. And this is the core principle behind using weighted utensils or gloves or even activity-specific braces that are available on the market, different companies that can help with this. Then there's more adaptive equipment, which is really trying to reduce the when you're performing an intended maneuver and not just holding a posture, you're trying to reduce the impact of the tremor on the activity that you're performing. So eating from a utensil, it certainly comes to mind easily, but in that vein, you can see that there are some gyroscopic utensils out there to reduce how much the endpoint, which is what you're holding on the utensil, is moving en route to your mouth, even though you might still be shaking no differently en route. It's just trying to adapt to your tremor. And the same thing goes for adaptive equipment using for computer devices. The quick one that comes to mind are the equipment used for mice. If you're trying to utilize a mouse on a computer, even though again you shake as you otherwise would, the impact on your movement on the screen would be minimized thanks to the technology available. So there's different ways to approach this for different activities. You can either try to reduce the tremor outright or just reduce the impact of the tremor. And then for medications, we talked about this at one point, but postural tremor often responds best to those that are most familiar with propranolol or beta blockers, as well as primidone, whereas they're perhaps a little less useful for intention tremor. When we talk about beta blockers, like propranolol, the pros here are that if you also happen to have somewhat elevated blood pressure, this could be somewhat useful if you have higher levels of anxiety. Propranolol can help reduce some of that, although I wouldn't suggest to use that as the only therapy. But if you have some, it could be useful. But it wouldn't be very much advised for anyone who is a chronic asthmatic or has emphysema or COPD otherwise, or has exercise intolerance, because we know that the medications, that whole category of medications, can reduce your ability to continue cardiovascular exercising within any reasonable time frame. So those are important things to keep in mind. For primidone, inherently, this is an anti-seizure medication. It has a very long duration for every dose. So which is why you can get away with dosing it simply once a day, since it lasts in the system up to a couple of days at a time. But it can be sedating for some, although for many, the sedating feature disappears after a few weeks on therapy. So certainly options that are available to us. And then if we're looking more for intention tremor, right, that's the most bothersome tremor as opposed to the postural tremor. Topamax is used, again, another anti-seizure medication that might also help if you have migraines. And often folks feel like it can make a difference on intention tremor, even at low doses. But if you already have a predisposition to kidney stones or are very dehydrated on a regular basis, kidney stones are a fear and concern. And for some folks at higher doses of Topamax can experience word-finding difficulties that would be frustrating inherently. It also is a medication that, because of how it works on tremor, at least as we understand it, can require taking medication 2 to 3 times a day at minimum in order to keep up with tremor suppression. So what do we know about the effect of these medications? In the case of primidone, we have a history of recording about a 55% chance of reducing tremor, and the degree of tremor reduction is variable there. The same thing goes with propranolol, but if you notice, when you combine primidone and propranolol together, that's what gets most folks the best rate of success, which is still at about a 70% chance. So not to say that it's high, and the impact may be low, but still useful for some. I have already mentioned about the Topamax and its use in intention tremor, but perhaps the studies show us more so that physicians, folks who are rating tremor, see a bigger impact than tremors do, than patients do, excuse me, on their tremor. And then the use of gabapentin, clonazepam, because there for a long time we didn't have a clear set of medications to offer patients, up until maybe even the 90s. This is still medication utilized by quite a few to try and see if we can make a dent on tremor, but it's not clearly useful in the available data. So again, maybe a case-by-case basis, but less obviously the case across the board. So what is the best practice that we use before considering surgical options? In truth, a combined approach between occupational therapy and medication, because neither of those on its own seem to be sufficiently beneficial. So in combination, actually might quite well be. And certainly we've found that recommendations we can give folks with both providers in mind, a therapist as well as a physician, often are quite a bit superior and may delay a recommendation or consideration for something a bit more aggressive or invasive. All right, but now let's say we are past that point. We're past the point of considering the more conservative options, and now we feel as though there's a need to consider something more advanced. So the good thing is surgical techniques that are available are FDA approved. We have a traditional, what's called a thalamotomy. This is actually what led to or sort of paved the way for other therapies that currently exist and are truly utilized today. Here we used to have to open up the skull in some format, use a heating device that was placed into the brain to burn the tip of said device in order to make a selective targeted lesion in a spot in the brain identified as a meaningful place to reduce tremor. In the late 80s and throughout the 90s, there was study of deep brain stimulation using wires inserted into the brain, same location as what we were doing with the traditional thalamotomy, in order to stimulate that area instead of creating a lesion to begin with. This requires attachment to a pacemaker in order to drive stimulation or electricity to that spot in the brain. And so you will live with hardware that continues to drive or deliver that stimulation, over the duration of therapy. And this was first approved in 1997. And then in 2016, in the United States, we get the approval of focused ultrasound ablation, in some ways harking back to thalamotomies, but really never having to open the skull in the first place. Use of high frequency ultrasound beams that are collectively coming together to produce a much finer tuned, smaller lesion in the same spot that we are interested in affecting, but while minimizing the risk of those side effects that could occur with any of these procedures. So let's move into focused ultrasound ablation. Again, here, what are we doing? We're performing that precise lesion or hole in the recommended location for tremor reduction. We're honing, over 1,000 but it's over 1,000 ultrasound beams that are being delivered with increasing intensity with the intention of heating that spot. And this is all performed through a dome that is placed over a patient's head while they're in an MRI scanner. And you are in an MRI scanner to deliver all of this therapy. So there's that need to come in and out of a scanner several times as we assess the changes performed by the procedure. You are awake and your head is shaven for this procedure. And for a successful procedure, if you're not awake, you wouldn't be able to understand what the temperatures that we are producing through the therapy are doing to your body, let alone to your tremor. So really any sedation is thought of as negatively impacting the results of our procedure, because sedation also reduces tremor, and then it's hard to follow the effects of what we just performed. Your head is fixed, and we'll show you a picture here. Your head is fixed to a frame that is fixed to the bed around the dome that you see on the picture ahead of us that is attached to the MRI bed. And this is all done in order to keep movement from occurring, because any movement, I didn't mention this earlier, but in all of these procedures, the area of interest is millimeters long, millimeters wide, millimeters deep. So we really need to have a very good level of control over variables like movement. So the head needs to stay fixed throughout this procedure, but you are awake for it, interacting with us quite on the regular, quite frankly. And there's no audio here. I'm just showing you the video of what's transpiring as we're performing this procedure. So, we are doing these assessments out of the scanner, but on the bed. Again, the head's fixed to the MRI. So the head frame is fixed to the MRI bed. You're coming into the scanner. We're measuring temperature, regulating that through a number of variables that we thankfully have control over, and Dr. Krishna plans out for every case. And then we bring you out of the scanner to test the effect of having done that heating mechanism, first by increasing the heat slowly, testing for any side effects while someone is having the heating process occur, and then delivering the final therapeutic dose, which is ultimately the higher temperature dose, once we feel that we've cleared ourselves from a higher likelihood of side effects, but also maximized our chances of getting a meaningful tremor benefit. And you're seeing that sort of through this cartoon here, trying to give you that thought, and ultimately seeing that change right on the table, right after the therapeutic dose is delivered. And then that's a really important feature to this, which is ultimately the ability to heat up things before you burn the area of interest. Heating things up just gives us a lot of useful information to tell us if we're developing any weakness, if we're developing any sensation difficulties, coordination difficulties, speech difficulties, which can come from any one of those areas. And so knowing this and testing for it, again, gives us that feedback that we're either in the wrong place before we finally burn this small lesion, or we're in the right place and we're safe to move forward. For this, we need folks awake. And then MRI scans are performed quite on the regular here. They're short duration, but ultimately we finish the therapy with one last scan to understand just image-wise what we've done. And then we have, these are still the traditional results that are talked about here, but we keep refining the procedure through multiple efforts, certainly at our institution and others do too, in an effort to maximize the benefits, minimize the side effects. But what we traditionally talk about is this roughly 50% improvement in tremor scales across those who were studied otherwise, and then maybe a 10% drop in the exact same benefit, which is otherwise shown here on the multiple graphs. But quality of life and disability scores persistently stay improved, even with these small we'll call it loss of tremor suppression, but it's only by the numbers, less by the report from patients, which are from these quality of life and disability scores. And that's part of what you're seeing here as well, in the blue as compared to the red. The red would be the sham, so that's that someone did not receive the therapy on the red bars here, but did receive them on the blue bars. And then at 2 years, and now we do also have 5-year data from some groups, but certainly at 2 years, we're still a significant improvement in those disability scale scores, which the lower the number, the better. And then approximately 40% of those who were here still showed at less than a 50% improvement in about 2 years, but it's still an improvement compared to baseline. So these are important features, especially for a procedure where it's kind of a one and done as far as we speak about. We really want to try and do this and hope to get the most out of this one single procedure possible. When we talk about side effects from this procedure, certainly folks can experience during the procedure dizziness or a sense of floating. Nausea can develop, and we watch for this very carefully throughout the procedure. Headache as well, but usually the headache is as the heating process is going on, as opposed to something more persistent, much less common in terms of being anything persistent. And the same thing goes for a warm, flushing feeling over the scalp and tingling and numbness. But again, usually transient, just as the procedure is going on. Now, when we talk about something that's more long-term coming out of the procedure, we do know, excuse me, we do know kind of in the bottom half of this table here that traditionally the numbers we quote are that people would get somewhat more frequent sensation difficulties. Changing the technique as it is recently, we really see this very rarely these days, probably closer to less than the 3%, sort of in the speech range here. Balance and coordination issues do come up as something we need to be more concerned about. Our program is exceedingly cautious about this particular side effect, and we're testing for it in multiple rigorous formats on the bed to be sure that we minimize the risk of that happening. There is also just watching folks over time. We know that ataxia is synonymous here with coordination difficulties. Traditionally, we talk about a third of patients within 3 months having some of that coordination difficulty, but even traditionally talk about that being present in 1 out of 10 patients at a year. We believe we're seeing lower numbers thanks to the additional testing that we're performing as of recent. So hopefully mitigating that. Here being sensory abnormalities used to be a quarter of patients. Again, this is becoming something that's closer to less than 5%, if that. Speech difficulties are still in that range, as well as weakness. So things that can occur and can linger at a year if they're not related to, per se, swelling around the area of the lesion, but just things to keep in mind as we talk about the benefits, but also the risks associated with the procedure. We perform one side at a time. Thankfully, there is an approval for this to be done on both sides to affect tremor on both sides of the body. And we focus on the effect on hand tremor or upper limb tremor. But the approval that comes for doing both sides requires that you do one side of the brain, wait 9 months before reviewing candidacy for the other side of the brain. A lot of this has to do with a history of the traditional thalamotomy, the way we used to do it even before DBS. We would see with performing the procedure on both sides a greater risk of balance and walking trouble, of numbness, of speech difficulties. There's a feeling that we were able to really reduce that risk, probably because if we run into any issues to begin with, we wouldn't go do the other side because that's just more likely to create problems. But nonetheless, we require a 9-month minimum between therapies. And I already alluded to that here. So then comparisons that often get made because folks ask us to make them. Certainly we think about these, but they're both very viable procedures between focused ultrasound and deep brain stimulation surgery. Some early and important points here is that for both procedures, your head has to be shaven for both of these procedures in order to undergo them. There is a frame of sorts that has to be performed or placed on your head for both procedures. In the case of deep brain stimulation surgery, some centers, ourselves included, have a quote-unquote frameless system where your head is not fixed to a bed, but nonetheless, we need to somehow have a way to plan your surgery, and there's something placed on the head that relays that information. MRI scans are required throughout the procedure for focused ultrasound. We do need an MRI before deep brain stimulation surgery because this is something we need to plan out your procedure. The detail that we get out of MRI scans for your brain anatomy really are not paralleled. You can't get the same out of CAT scans, so we do require that. But that could be done if absolutely necessary under sedation. And I've already alluded to the fact that this is the same target. So both of these procedures are being performed on the same target. Average time that we experience focus ultrasound, so for a single side, between one thing or another, the whole experience is going to be between a 2.5 to 3 hour process for that entirety for a single person. Again, if you wanted to get both sides done, we're waiting 9 months between the procedures, but there's no implanted hardware. If the tremor does return, we could potentially repeat the procedure, but we'll be reviewing a lot of any symptoms or side effects that you experienced from the first procedure, and likely looking at the imaging to make sure that it makes any sense to go back in and try to burn a second lesion in the same spot or relatively same spot. With deep brain stimulation surgery, it can be done one side at a time, but we usually recommend for someone who can to undergo the procedure and place both wires, both sides of the brain in the same procedure. Despite doing both sides of the same procedure, The brain portion of this procedure, where we're placing the wires and fixating them, is a 3.5, 4.5 hour endeavor. So a little bit longer, though both sides are being performed in the same procedure. Of course, there's implanted hardware because that is exactly what drives the therapy. And then if the tremor returns, in theory, unless the placement of the wires was not accurate, we can continue to make adjustments to the stimulation settings past that procedure without requiring another procedure. So, um, you know, so I'll say this in summary, and then I'll finish with one last point about surgeries. Let's remember that essential tremor ultimately is a syndrome. We don't have any testing that tells us this is your diagnosis. We have criteria that tell us this is your diagnosis. Any testing is to rule out other conditions, but making sure you have the right tremor type is important so that we don't inadvertently start treating the wrong condition. To that end, we should be tailoring all therapies to your specific cause of tremor, or at least kind of tremor, if not cause. But unfortunately, cures are desirable, but not yet available for any of our tremor syndromes, really, unless it was medication-induced tremor strictly, I suppose. Focused ultrasound ablation is available and certainly an advanced therapeutic options along with deep brain stimulation surgery, and offers a minimally invasive option for those who are hesitant about putting in hardware or don't easily qualify for deep brain stimulation surgery. The point I was going to make here is that ultimately we don't think of these as competing therapies. We think of them as complementary because we have options for patients, right? So we can really tailor, like we do with medications and occupational therapy, we can tailor recommendations to you about ultrasound or deep brain stimulation surgery, or perhaps some sort of staged approach over years with different therapies available in order to meet your goals to the best degree possible. So we don't just sit here and think about competing interests between these two kinds of procedures. And one important feature about focused ultrasound is that the heating prior to the burning process offers us that opportunity for testing the effect, but also testing for side effects to help us reduce the risk of those long-term side effects coming out of an ultrasound procedure. So wrapping quickly up after that summary is just wanting you to meet our team. So on the focused ultrasound side, Dr. Vibhor Krishna leads the ultrasound therapy team. I'm his counterpart on the neurology side, helping with these procedures during each one of these procedures. So Dr. Krishna helps in creating the plan for and delivering these therapies. I'm there to help us fine tune it throughout your procedure. So I may know you and meet you from prior, or I may meet you the morning of the procedure. But we are both involved in order to really personalize and maintain safety throughout the procedure. And we have really found that team-based approach is just so valuable to maintaining that personalized level of care that we really strive for. And then, as Dr. Krishna was mentioning, we have our very unique tremor interdisciplinary clinic. This is truly first of its kind in the country. And it's a full morning of at least 3 up to 4 hours worth of different visits with different team members. This includes myself as the tremor movement disorder specialist, Dr. Krishna as a functional neurosurgeon, one of our occupational therapists who comes in and assists us with testing, but delivering information on adaptive equipment versus weight-based and tremor reducing equipment. And then we have a whole other host of team members, including our nurse educator, coordinator, our research coordinators, in case you have interest in particular research protocols you might hear about or see out in the community, or just want to learn about what we have available. And then we do work with one of our biomedical engineers who collaborates across UNC and NC State in terms of trying to analyze tremor, so that hopefully tomorrow, in the days of tomorrow, we have an opportunity to maximize our understanding of tremor and offer treatment options therein. So with that, I'll leave this slide up. This is just our referral information for those who are looking to reach out, ask for an appointment, or even ask your providers, for referrals out to our clinic spaces. And I truly appreciate your time and attention in this afternoon's discussion.
Thank you, Dr. Roque. This was a very exciting talk. And I have to say this every time. I learn a lot from your talk, and this time too, I found some good pointers. I wanted to get us started with some questions that we get asked often. And so with your expertise in tremor, um, recently, we've started to think about, as you say, tremor is a syndrome, uh, some other symptoms that could also present with tremors. And so, can you specifically educate us about balance issues sometimes that come in tremor patients, and what does that signify, and how do you advise patients to manage that?
Certainly, and this is a crucial point about the diagnosis. So we, as much as essential tremor is its own diagnosis, and again, we have these updated criteria, right alongside them, we've recognized for decades, but especially in the last 6 years, that and we have now categorized a whole group that we call essential tremor plus as a diagnosis. Essential tremor plus, not to be too simple, it just means that you have in addition to the essential tremor criteria, you have additional neurologic issues that we can identify that we know and have known for decades can come with essential tremor, but don't suggest a separate diagnosis or label akin to the rest tremor being present in essential tremor. In the case of balance issues, coordination issues, we refer to this as ataxia. And ataxia can certainly manifest in your trunk. So in terms of just walking and walking in gait difficulties can manifest in your arms or legs, being clumsy in the arms. And I'm saying clumsy beyond the effective tremor, just difficulty coordinating your limb movement as reliably as you were hoping to, or your leg movement as reliably as you're hoping to. And this is perhaps one of our understandings in the present time, and we hope it will manifest into more over time, is that we're working off of a current basic theory that perhaps one of the places in the brain where tremor originates, or this condition originates, is within the coordination center of the brain, referred to as the cerebellum. The cerebellum, since it is the source of ataxia whenever someone develops difficulties with coordination, it goes to show that we feel as though easily 20% of patients with essential tremor, if not more, also suffer from ataxia. The moment you have coordination troubles, you already start to qualify for essential tremor plus as a result. And this is relevant for the surgical procedures that we have available. We are working in an area that is very close to where the fibers for coordination are located. And so this is an important symptom to study, to evaluate in every person with essential tremor, and to ultimately ensure is maintained as a factor whenever we're planning out surgical options.
That's great. Thank you. Sometimes, so you mentioned about the equipment that sometimes helps with reducing tremor. Um, Patients sometimes would come in and say, is there a role of exercise in improving tremor, especially in early stages? What do you advise patients around that?
In essential tremor specifically, and when it comes to tremor, exercise is a tricky situation. And this may very well resonate with folks who are attending this session, in that we know if you are using a lot of weight-based exercising, right? So you're doing weight training, especially with free weights. At the moment you're using the free weights, it's less of a problem, right? So you can activate muscles without much of it. You might feel a little bit of the tremor through it, but it's not intruding on your ability to perform the exercise. But as soon as you drop those dumbbells, you start shaking harder, right? It's the stress of having gone through and performing the physical stress of that weight-based exercise. But now you've removed the weight on top of that, and like it's sort of counterintuitive to what we otherwise know from weight-based therapies we use, finding that sweet spot of not being too heavy but being heavy enough to utilize weighted utensils and the like. So that plays a role there. For cardio, it's just as tricky because if you really get your heart rate up, that is a physical stressor that enhances your tremor until you really calm down and your adrenaline drops. So, this is not to say that we want you to stop exercising, and please don't let this be an excuse to anyone on the call, but at the same time, it's recognizing that these will happen and it's okay. It's part of what you otherwise will experience. I hope would be reassuring so that you don't feel alone. You certainly don't feel alone.
All right. Before I let Sam ask the questions from the audience, there is a request, Dr. Roque, to put the slide that shows long-term outcomes after focused ultrasound on the screen for a little bit. One of our participants would want to look at that slide a little bit more. Yes,
Okay.
that's great. And so just so everyone knows, this graph shows individual patient level data. And on the left, the y-axis or the long axis is the percentage reduction in tremor. And each bar represents a single patient. And this is at 2 years time point. So you can see that there is a range of relief in tremor. Some patients are close to this 90 to 95%, and others are close to this 10 to 20% tremor relief. And so there is a full range.
And I'll add to that they were purposely organized this way to make the graph look and appear this way from those who had the highest results to those who had the lowest results. But in effect, what we're seeing is that all but 2 patients really had some 2-year sustained benefit, whether it was, higher up in the 90% reduction range or lower in the 30-20% reduction range. So reduction, yes. And so that's kind of the part of the point here.
That's great. So Dr. Roque, another question that comes up is sometimes patients want to know when is the right time to consider treatment of essential tremor with surgery. Is some time point too early? Is some time point too late? And as we know, the tremor changes over time. Certainly, how would that factor into the decision making for a patient?
It's a great question, and yes, we do get this question a lot when folks come to visit us. You have to think at least of a couple. I'll speak about 2 highly important variables, but there are more. One of the most important variables is a quality of life question, right? So if I often tell folks if their tremor is more than just mild tremor, and mild is very mixed, objective, subjective, right? So someone's coming in for just wanting to know what they have as opposed to necessarily treating it. And I agree that they have a mild tremor. Perhaps the risk of going through a brain surgery at that point won't make much sense. But if you're running into quality of life issues, you're running into difficulty maintaining your daily hobbies, your daily work activities, your daily home activities, socializing because you're embarrassed by the tremor, these are real life implications of the presence of that tremor. And you certainly could wait longer. So that what I tell folks here is about, do you do it earlier or later? If you're at a point where we think you could benefit from tremor, it then boils down for you of how many years of benefit would you hope to get out of the procedure, right? So acting now to get benefit now versus waiting years later when you may have other health issues that arise, are important factors, but very personal factors, right? And questions only you can answer as to whether you would want to really maximize the effect of the procedure on your life for the number of years to gain, basically. The other has to do with medications and medication burden. So folks might feel like, okay, well, I'm getting something out of my medications. I think I'm going to drive this and run this as long as I possibly can, which is in some ways respectable, but in other ways as maybe depending on your personal situation may actually just be signs of stubbornness if you think you're actually still going to want to go through this procedure at some point in time. But that's really what it boils down to when you hear the details of what these procedures offer. If you would never do this, don't worry about the idea of delaying the procedure, because you're in your mind, you probably would never do this, right? That's an important consideration just as much. But if you really think you would, and you feel like you are losing aspects of your quality of life, whether because of the impact of tremor or because of the sheer amount of medication that you need to take, those could be very reasonable considerations to do this earlier than later.
Thank you. I think this is great. And summary would be that it's the patients who drive that decision making, as you said. and, sharing how much impact it has in your quality of life with your physicians, and where that falls with the severity of your tremor, what medications have you tried, helps you make that decision. Okay, that's great. One question that I can take here is the procedure still dependent on skull bone thickness? And the answer to that question is we do skull bone thickness to understand how difficult or how easy the procedure is going to be. There are certain thresholds that help us decide that. But in the recent past, we do the test to understand, but we don't exclude patients unless we have significant concerns that the skull is going to be a major barrier in doing a safe and effective treatment. And so that's the answer to the question. There is a question around Parkinson's disease, Dr. Roque, and if you are okay, I can ask the question about this. The question is that after 15 years of Zyprexa-associated tremors in Parkinson's that otherwise responds well to Rytary, roughly 8 hours out of a 24-hour day. And they are able to walk well, lift weights, punch bags successfully, but still have tremors. So the question is, am I a good candidate for focused ultrasound in this scenario?
I think it's always tricky taking short snippets of somebody's life to make good decisions about whether someone would be a candidate for any surgical procedures. I think some takeaways I get from this is that, unless I'm misunderstanding, we're only getting about a third of a given day. Now, granted, we're not awake for 24 hours, so maybe let's assume this is half of the day, half of the waking hours with tremor control, but that's still half of the day without tremor control. Despite, I'm going to assume, adequate attempts at trying to reduce the impact of tremor through medication. That is it becomes entirely up to you whether to consider pursuit of focused ultrasound. Now, I'll add to this that knowing that we're having to be on Rytary, and granted you're able to maintain otherwise a lot of your activities on check, the ones that are important for you, that's a high pill burden as far as I can tell without getting into greater detail. So there could be a role if tremor is really what's driving the medication. It may not be, but if it's what's driving the medication, there could be a place for really considering it to see if there's a chance to reduce it. But and that's a very, very superficial way of answering a very personal question.
Yeah, thank you. Thank you for attempting to answer this. I totally agree that sometimes this would require someone to just sit down and really have a deeper dive into understanding how the symptoms are and how medications are significantly impacting that or not. Okay, so the next question, I can take this one. It says, how long after a successful CT scan can I expect to schedule the focused ultrasound treatment? So in general, what we recommend is that if you have a CT scan within the last 1 year, that there is a reasonable chance that anatomy and the skull thickness and the density would remain the same. And so within a year of having the CT scan, it's reasonable to use that same CT scan for a focused ultrasound treatment. If you wait longer than that, then it can become an issue. And it's not saying that, if you have 13 months, that's over 1 year. So it's a way that you can sit down with your treating surgeon and understand. Usually we keep the limit of 1 year. And so we'd like to keep it 1 year.
And Dr. Krishna, I'll ask a question that I know comes up not frequently here as a piggyback question. Now, can this be a CT scan done anywhere, or do we need to get a CT scan at a specific location?
Yeah, so that's a great question, Dr. Roque. And so the answer is that the CT scan has to be acquired in a very specific way. And so it includes certain parameters, certain types of filters that allow us to appreciate the bone in greater detail. And so there are centers that can do this. And so we have had patients bring in their CDs from other centers, and we were able to use it because they use the protocol that we need. But it's not the routine CT scan that we sometimes use for assessing someone who comes in, say, for example, with a headache to the ER. So this is a very different type of CAT scan. And so this is a CT scan specifically done for assessing someone for focused ultrasound treatment. In general, we prefer that you get the CAT scan done here at UNC, but if you have a center that has done this in the past successfully, we are happy to use that, and we have been able to use that CT scan in the past. And there is a question from the same participant. They're saying, how quick can I get the treatment at UNC? I'm tempted to say we can do it tomorrow, but tomorrow's schedule is full. And so the last time I checked with our coordinator for focused ultrasound treatments, we are currently scheduling in the first week of March. And so this is roughly like 4 or 5 weeks that we are scheduling the treatments. And so happy to help anyone if you're interested in that. Now, question that came up, Dr. Roque, and I don't know if you will be able to answer this. They say, I apologize for reiterating this question, but I see new faces. Has anyone heard of Ayurvedic medicine? And the subject talks about having falls and fainting, and unfortunately even having injury that has resulted in loss of some teeth.
I admit I have not, so I apologize. I'll have to defer. I might take a quick look as we think of another question and see if maybe this went by a different name that I wasn't aware of, but unfortunately not. And it clearly has more to do, whatever this is, has more to do with other sets of symptoms.
Yeah. Yeah, so Ayurvedic medicine, from the context that I understand, has been practiced in India and looks at herbal medications for treatment of various conditions. I personally haven't heard of Ayurvedic medicine in the context of, say, falls or Parkinson's disease, and so please pardon my knowledge in this area is quite limited. Okay. The next question, Dr. Roque, is what are the two medications that work together that gave the best results? In your slide, you talked about
Oh.
two medications that work best together. Can you please share what the name of that medication is?
Yeah, correct. Yeah. So the best available research data and honestly practical data tells us that when you combine primidone and propranolol together, that's where you get the best results from any combination of the available medications on the market, the oral medications on the market. Yeah, and that can get up to about a 70% chance of a tremor change, right, as opposed to more than that.
Okay, very good. So the next question I have is sometimes patients would talk about how should I think about getting one side of the body treated versus both sides, in what order, and how should we think about that?
Yeah, so thinking strictly of essential tremor, where we have this option to treat both sides, in focus ultrasound, the reality is it has to really, I think it becomes so personal regarding goals that someone has with the underlying condition. Invariably performing a procedure on both sides is going to require two separate procedures, two separate brain procedures, which can be very reasonable, right, in the setting of wanting to reduce the need for anything like internal hardware from deep brain stimulation surgery. But also there's a degree of thinking even in the graph in front of us here that we still have posted, were you happy enough with getting a 30% reduction of tremor? Were you happy enough with a 60% reduction of tremor? Which to do anything different would require yet another procedure, yet another focus ultrasound procedure. Invariably, we know that there are hardware implantation is not a small thing for something like deep brain stimulation surgery. For quite a few patients we see, it is just not a consideration. So, the truth is, if you want to go through one side procedure, see what you get out of focus ultrasound, and not infrequently when we still see folks in follow-up, they weren't sure they were going to go for the other side, and they got so excited about the end result from the first side that they're asking us when and how to sign up for the other side. But what is your end goal? Again, thinking of the hands, and I don't want to get deep into because there are deeper conversations to be had about head tremor and voice tremor and lower limb tremor. Those conversations are more complicated. But when it comes to hand tremor, um, it is extremely reasonable to pursue I want to see what happens with this side and don't want to have anything implanted. I don't want to have several visits with my provider to tweak my device. I just want to have it done and see what occurs. That's very, very reasonable. In fact, there's one truth that we didn't discuss in today's talk, but there's one truth to all this, which is that you could perform focus ultrasound. And if focus ultrasound doesn't quite go well for you or not well enough, we could also subsequently implant DBS hardware, right? So you're not stuck with only one choice, and it may be a very reasonable approach to start with ultrasound. If that doesn't go the way we want it to, then perform DBS. But I also see the other side of that coin that comes into clinic, and I have folks who say, I want to minimize the total number of procedures I need to have done on my head. Okay, technically, that's deep brain stimulation surgery because we can place both wires in at the same time. Yes, it requires a second procedure to attach all this to a battery and pacemaker, but that's not another brain surgery. So ultimately, there's so much flexibility there that goes back to the comment I left us off with of, personalizing this to your goals and personalizing this to what we think is achievable with each method of providing advanced tremor relief.
Certainly a very exciting time as you share that we have different ways, and it's a great time to sit down and chat, understand what the goals are for individual patients and priorities, and feels good to be able to help patients in the way that can make a meaningful difference in their quality of life.
Absolutely.
Another question, Dr. Roque, that comes is, can medications you suggested, propranolol and primidone, be utilized with metoprolol, Eliquis, and some heart rate palpitation kind of medication, or can they contribute to my tremors? Do-
No, that's okay. So there's a lot there, but I'll break it down to this concept. As neurologists and certainly as movement disorder specialists, we have to think a lot about drug interactions, a lot. And primidone, for one, is a drug that can interfere with liver enzymes that are important for different medications being metabolized. Sometimes it excessively metabolizes the drug, and other times it stagnates and keeps a drug from being effectively metabolized. Topamax is another drug that can do this, but to a lesser degree. So these are important considerations with any medication you might be on. So I would never suggest, in fact, that the initiation of anything except maybe propranolol, and I'll get to that in a moment, is something that you could simply start without understanding someone's active medication regimen, because you can have negative impacts. And among them, you mentioned an important question about blood thinners. Blood thinners absolutely can interact with these medications as well, where we make them less effective, right, through the use or introduction of primidone or Topamax. In the case of propranolol, mixing propranolol and metoprolol is frowned upon by anyone that we've ever tried to do this with in our community and in my practice across other sites as well. So I always converse with someone's primary care doctor or cardiologist who might be prescribing your medication, your beta blocker, otherwise. And I do ask if there's an opportunity to switch from metoprolol perhaps to propranolol, only because the data is more prevalent. Like, right, the effect of tremor reduction is more prevalent. I can't tell you exactly why, but I can also tell you in the same vein that there are plenty of small studies that suggest metoprolol, atenolol also have positive impacts on tremor. So that might make it that someone doesn't really want to reinvent the wheel on a beta blocker. Just you're on one. Okay, that's the one you're on. The question, though, is propranolol has a lot of flexibility for adjusting the dose compared to atenolol and metoprolol, which are the other common beta blockers. So it may be that we can't safely bump up your other medications, and that might be a reason and rationale to switch with your other provider's help.
Thank you. That's a very informative answer. The last question is, what doses would you recommend if you try the two medications, primidone and propranolol, just in general, the starting dose? I know it's difficult to pin
Oh,
down.
no, that's actually a better question. I was going to answer a different question, so I'm glad you finished with that. So starting doses are critical actually in propranolol and primidone. In propranolol, because some folks get really a lot of exercise intolerance, even at 10 to 20 milligram doses, I start that low. I start at 10 milligrams, 20 if I'm being a little more bold, and slowly titrate that up by 10 milligrams a piece, often once a month or every 2 months, just so that you can tell us if there's something that's changed on the negative side alongside the tremor reduction. And usually also have you take your blood pressure kind of at least once a week at the same time, same circumstances, to make sure we're not running into a drop in blood pressure or even your heart rate that is significant in that time frame. In the case of primidone, even at 50 milligrams, I have found that, and so have many of my colleagues found that 50 milligrams is simply not tolerated. That is the lowest pill size of primidone, and is simply not tolerated. Even if you take it at bedtime, which is what we recommend doing, it's just not tolerated from the standpoint of sedation. So it will always sound somewhat aggravating, especially if you are the one trying to cut this because of your tremor. But asking someone to initially split your 50 milligram pills into quarter tablets, there's no score on the pill for this, but you try your best to get quarter tablets. And we usually start at a quarter tablet, which estimates to 12.5 milligrams of primidone. And you do that every night for a week and then increase it by another quarter until you reach 100 milligrams. And then that slow titration allows your body and your brain to get used to and never really fully feel sedated the way starting on a 50 milligram pill often does for most patients. In terms of maximum doses, there are maximum doses, and propranolol usually maximizes at 160 milligrams before it gets problematic, or at that point, really, if you haven't seen enough benefit, we don't expect more. And then for primidone, a total of 250 milligrams per day is a pretty clearly delineated or defined maximum dose. Folks may experience providers asking you to take higher doses, but not experiencing an improvement beyond the 250 milligram dose. So I usually do not push that number just because the chances it will have any further effect are effectively zero.
That's great. One last question is, if ET is not treated, then does it get worse and worse over time?
Yeah, the short answer to that is it going back to the fact that it is progressive. So the short answer is yes. The question that always is a relevant one is, when is it going to get worse and how much worse is it going to get at that time? That's the crystal ball we don't have access to. We just know that progression in some fashion is invariably what will occur.
Excellent. Very good. Thank you, Dr. Roque. This was a great presentation. We learned a lot. Sam, things that you had to say?
Oh, you're muted right now.
There we go. Thank you all for your time, and thank you for taking times out of your schedule to educate all of us on tremor and options available to us. If there's no more questions, that concludes the presentation for today, and we'll see you for the following one in March.
Thank you,
Thank
folks.
you all.
Thank you. Bye-bye.